Hello, and thank you for taking the time to watch this webinar on caring for residents with MS. My name's Bridie, and I'm one of the nurse advisors here at MS Plus. And I'd like to start by an acknowledgement to country. MS Plus acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders, past, present, and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. We also acknowledge our gratitude that we share this land today, our sorrow for the costs of that sharing, and our hope and belief that together we can shift to a place of equity, justice, and partnership. This is me, and I've just introduced myself, and I'm looking forward to presenting this. As your client is in care, I assume they have significant care needs. So I'm hoping this presentation may give you some tips to support your resident. What we're going to cover, I think it's really important whenever we're sort of talking about looking after somebody with multiple sclerosis to have a bit of an understanding of what is MS, the common symptoms, how those symptoms might present, and when to reach out for advice. So some of those sort of red flags, challenging behaviours, and then hopefully we'll be able to sort of talk through some strategies for supporting your resident. So let's get straight into what is MS. So there's a couple of little pictures here to try and illustrate what's kind of going on. So when we're talking about MS, we say multiple in time and place, and sclerosis being Latin for scarring. It's actually the most common acquired chronic neurological disease affecting young adults. And it's often diagnosed between the ages of 20 to 40, and in Australia affects 3 times more women than men. And yet there still is no cure. There's no single cause for MS, but many genetic and environmental factors have been shown to contribute to its development. So what happens in MS? The body's own immune system mistakenly attacks and damages the fatty material called myelin around the nerves. Myelin's important for protecting and insulating nerves so that the electrical messages that the brain sends to the rest of the body travel quickly and efficiently. As the myelin breaks down during an MS attack, a process we call demyelination, patches of the nerves become exposed and then scarred. That renders the nerves unable to communicate messages properly and at risk of subsequent degeneration. This means that the brain cannot talk to other parts of the body, resulting in a range of symptoms that can include a loss of sensory, motor, and cognitive function.
Okay.
So just for a bit of interest, I've put this little table in. It's adapted from work by Professor Robin Lucas of the Australian National University, who's just put this together. And it's just a little interesting piece for you to sort of have a look at. MS is a complex interaction between genetics and the environment. How you respond to your environment depends on your genetics. So these are some of the things, and it's just got a little table of risks and risks of disease progression. So, for example, your genetics determine how your immune system responds to, for example, an EBV infection, which is the old glandular fever, and how you process vitamin D, for example. Your sun exposure determines how much vitamin D your body makes. So you can see that there is a bit of complexity in this. The smoking, as in cigarette smoking, adds additional inflammation into an already volatile mix. Diet, physical activity, and stress may also contribute to this mix. Potentially, there is also other as yet unknown factors which might also lead to an increase in inflammation or be able to mimic or add to the role of some of the factors listed here. And only a few of these factors may come together in some individuals to trigger MS. In others, it may be an accumulation of many of these risks and factors together, and the combination will be different in different people. The evidence supports the risk of developing MS, but research is ongoing in both areas. So I guess a really good place to start is trying to explain the different types of MS. So the three main types that we talk about are relapsing, remitting, secondary progressive, and primary progressive. And I suspect that if you have a resident with MS, they're probably in more of a progressive phase, given that their care needs are probably a little bit higher, requiring that 24-hour care. So if we're talking about relapsing remitting MS, it's the most common form of MS. It's characterised by flare-ups of the neurological symptoms of MS, also known as relapses or attacks. And we'll talk a little bit about that in a couple of slides. And then it's followed by periods of recovery or remission. Secondary progressive MS is characterised by progressive worsening of symptoms, so an accumulation of impairments over time with no obvious signs of remission. And primary progressive MS affects about 10 to 15% of people with MS. It's characterised by progressive worsening of symptoms and disability without periods of recovery or remission. So interesting. This is a great slide. I love this slide. It's most of the common symptoms we see in people with MS, now, regardless of which sort of MS we're sort of classifying it as. This is basically an overview of those symptoms, but I love the way that this has got sort of percentages of those experienced. And the sad thing about MS is that a lot of the symptoms that are the most disabling are the ones that are invisible. So things like fatigue and pain and cognitive dysfunction are really, really troublesome to somebody who has MS. But from the outside, you can't actually see that. And sometimes it can also be very, very difficult for those people to verbalize or explain what these symptoms are feeling like. So have a look at this and you might find that you can relate to some of these symptoms with your resident that you have. I think at this time, it would be really good to and important for you to know what an attack is. So when we talk about a true relapse, attack or flare in MS, we're talking about a relatively sudden, over hours or days, episode or new or worsening or of existing or new symptoms. And they must last for at least 24 hours, but more commonly for a number of weeks. And they must occur at least 30 days after the start of a previous relapse. There must also be no other explanation for the onset of those symptoms, such as an infection or a rise in body temperature, and I'll explain the difference in a minute. So the immune system attacks the myelin covering of the nerves, causing inflammation and damage to the myelin. So we call that demyelination. In MS, the messages pass along a demyelinated nerve more slowly or are blocked, causing a variety of symptoms. And it depends on the part of the brain or the spinal cord that's affected. For example, they might have blurred vision, numbness, tingling, loss of balance, increased fatigue, weak muscles, bladder or bowel changes. Now, if we compare that to what we call a pseudoexacerbation, a pseudoexacerbation is not caused by new damage. That's one of the biggest things. It's brought on by other influences. We find that a urinary tract infection is probably the most common cause, and it usually subsides within 24 hours. So potential triggers that we talk about, urinary tract infection, as we just mentioned, exercise, stress, heat, other types of infections, recent vaccination, and sometimes even hormone changes. So if you've got a resident that's sort of going through menopause or having menstrual problems, that could be enough. That could actually set off what we call this pseudoexacerbation. The thing with these is, though, when you take the trigger away, the symptoms usually settle down, and that is the difference between a true and a pseudoexacerbation. So we've had a look at the symptoms and the types of symptoms that can be presented by each person, and what they might experience. And everyone will have them in different degrees. Some people might have some and not others, and they can chop and change even through the period of a day. But what's interesting is how these symptoms might actually present. So what you might see from this person, and they may not be able to explain what the symptom is that they're feeling, but they might be exhibiting some of these things. So, for example, vagueness, inflexibility, rigidness, impaired eyesight. You might notice they're overwhelmed, that they're isolating themselves and never going out. Maybe they're a little bit more irritable or more forgetful, more demanding. These are some of the words that we look at: lazy, disorganized. Maybe they've become quite hopeless with money. One of the things is that they can become quite use a lack of empathy of others. They might be cranky. Maybe they can't complete their tasks. They might be easily distracted, or they appear that they're not listening. I wonder if you've seen any of these behaviours in your resident. So if any of these sort of, are appearing and they're a little bit abnormal to how your resident might normally present, perhaps they're actually having a flare of something that is going on. And the other side of this is that sometimes your resident will have experienced many of these losses as a result. So physical independence and self-care. So they've had to go into care. Decision making, their financial health. Employment has gone. There might be a change in relationships and intimacy. Husband and wives have having to separate because one's gone into care. Can't drive anymore. Their social functioning and leisure activities have changed. There could be some cognitive decline. And that also includes sort of, short-term memory loss and lack of insight. So the cumulative effect of these losses that have led to admission to residential care or needing carers must be hugely challenging for these people. But if you've got an understanding of the losses that they've experienced, it will go some way to explaining how they are and help you to emphasize with them. Keeping in mind, this understanding will not always be enough to explain the behaviour you observe and experience. And it can be very different. And this isn't to say that all people have, these are things. You're going to get your positive people as well. But given that there's an accumulation of symptoms and increasing care needs, I guess we're sort of covering sort of the lower end of things where you might be experiencing some of these troubled behaviours and things that you need some support with to manage your person that's in there with MS. So we do use a lot of medication in MS. I'm not going to go over all the medications that are used because I suspect that if you do have a resident in care, they may no longer be on disease-modifying therapy. Some may be, but basically we do use these as our main treatment for MS. But we also use a lot of pain medications, analgesics and antispasmodics and muscle relaxants. We use a lot of mood medication, bowel and bladder medication, and often a lot of the medications can impact symptoms as well. But there can be a lot of side effects from the medications, depending on what they're on. It might be nausea, it might be sleepiness, it could be constipation, diarrhea, it could be increasing their fatigue. So it's really important also to have regular medication reviews and make sure that someone is keeping an eye on if something new is introduced, if there been a change in symptoms, and having a really good look at that as a part of assessing what's going on with that person. All right, so how do we support your resident? So we've established that they may have some of these symptoms. We've looked at how that might look to them, what they might be experiencing personally. So how do we support your residents? Now, I'm going to go through probably just a few of the more sort of common things. And what I would really encourage, if I'm going through some of this and we don't cover what your particular resident might be experiencing, I'd encourage you to ring into MS Plus and ask to have a one-on-one conversation with myself or my colleagues, so that we can sort of address what you particularly need to get some tips and tricks and some advice around. But fatigue is probably one of the biggest symptoms. Now, I love this little cartoon. The thing people don't understand about this condition is that it fluctuates. Just because I did a thing yesterday doesn't mean I can do the same thing the next day. And this is actually also true of the same day, not let alone the next day, because fatigue levels can alter, throughout the period of the day very, very easily. So we know everyone gets tired or fatigued at times, whether or not they have MS. A late night will make you feel tired the next day, but for 80% of people with MS, fatigue is reported as one of their top 3 symptoms. And in actual fact, fatigue is probably one of the main reasons, that and cognitive function, that a lot of people will actually leave work and struggle. So nerve fiber fatigue occurs when a nerve or group of nerves lose their ability to conduct signals to muscles during activity. So it's very, very different to a fatigue that anyone else would experience from a late night. It's often described as an overwhelming feeling of tiredness, like hitting the wall or being hit by a truck. It's also considered to be among the most disabling, and yet it's invisible to everybody else. And it's often interpreted as someone being lazy, and very, very difficult for someone who's not experiencing to understand the actual level of fatigue that this can be. It actually impacts the ability to complete the activities that individual would like to do each day. And the level of fatigue is different for each person, and as I said, can change even during the period of the day. The causes are complex and not really fully understood. And they do not seem to differ in terms of gender, do not appear to be related to age. However, fatigue does seem to increase with different levels of disability. So in actual fact, the more disabled you become, you see probably an increase in level of fatigue. So management strategies in a residential setting usually revolve around balancing activities, allowing rest breaks, and considering the impact of heat. OT and physio assessments to ensure balance, gait and mobility are at a maximum potential and equipment is relevant. Diet and water intake will also influence the experience of fatigue, as will iron levels, the amount of daily exercise and sleep quality. Cannot stress enough how important it is that someone with MS gets really good sleep quality, because we know for a fact that poor sleep increases fatigue levels, and when your fatigue levels increase, it exacerbates every other symptom that you potentially have with MS. So that leads us to talk a little bit about sleep disturbances. So, I'm sorry, go back. Managing sleep disturbances. When someone is really fatigued and if you notice that their cognitive functions declining and they're really, I suppose not getting into it as much as they would normally, always check how they're going at night. And I'm assuming sort of in a facility you've got regular sort of monitoring of your clients, but it would be really interesting to see and have a discussion with that person how they're perceiving their sleep to be. There's specific reasons why sleep may be poor. So it could be a location of the lesions, it could be pain, it could be muscle spasms, it could be frequent visits to the toilet, it could be depression and anxiety, it could be the medications that they're on. They could even have some sleep disorders. And there are other reasons which apply to everyone: the environment, worry, stage of life, menopause. The relationship between fatigue and sleep in MS has been unanimously identified in many studies. So, as I said, addressing sleep issue in people with MS is vital. What can you do about it? Routine: include exercise during the day and wind down activities in the evening. Light: have 15 to 30 minutes of bright light in the morning, because what they've shown is that can actually dampen the melatonin and encourage a sleep-wake cycle. So when we're talking about managing melatonin, we're talking about that natural hormone that's made in the pineal gland that controls our sleep-wake cycles. Avoiding light at night, so like your TV screens, computer screens, as we need those melatonin levels to rise again to sleep. Reduce caffeine intake, so just to monitor what your clients are actually drinking during the day, and particularly as the evening is drawing closer. Managing other symptoms like your bowel, bladder, fevers, mental health, pain, restless legs, sleep apnea. So have a look at all of those sort of things. Is the temperature of the room comfortable? You don't want it to be too cold. You don't want it to be too hot. So establish where your client is comfortable. Make sure their bedding is comfortable, that they've got an air mattress if they're prone to pressure sores or pressure areas, or if they can't move themselves from side to side. Medications to assist sleep and symptoms, and potentially an appropriate referral for sleep studies if need be. Review by the GP. Spasticity is a really big problem in MS, and often we find that people who can't move around by themselves as much and are losing a lot of mobility and self-independence may actually experience a little bit more spasticity, tremors, spasm, muscle tightness. Up to 75% of people with MS will experience some spasticity, involuntary muscle contractions, spasms, and stiffness. And it may also be associated with pain. It tends to get worse over time, particularly when people are too weak to move, as we've just discussed, and worse if your resident is fatigued. It can interfere with ability to be positioned correctly in bed or wheelchair or shower commode. So what can you do? Several medications can be used. More commonly, we see baclofen, and these are things that can be discussed with the GP. The timing of the dosages prior to care routines can help with personal care, can be fine-tuned and monitored by a physio in conjunction with the GP. Severe cases may require other methods. So, then we sort of talk about intrathecal baclofen, nerve block, surgical release of contractures and things like that. And we see Botox becoming a little bit more popular, but it's really only suitable for focal stiffness and it has a temporary effect. But if you've tried all of the above and you've got your physiotherapy and you've had your occupational therapy come in to look at, exercises, equipment, all of those sort of things, then, it may be that they need a referral for some more invasive intervention. Regular movements and stretches are part of normal care, and routine helps to minimize that stiffness and maintain flexibility. And the one thing to remember is that prolonged spasticity and spasms can actually cause pressure areas due to the friction on the bed in the wheelchair. So maintaining skin integrity is absolutely vital. Moods and emotions in MS. These are some of the things that we often hear with people, and look, they're completely normal for someone with chronic disease. But we know depression is a bit of one of the symptoms of MS, and we do see a lot of anxiety. But I'm wondering if you've noticed any of these emotions above, and if you've noticed any of these triggers. So grief, sadness, anxiety, stress, fear. These are all indicating that this person is struggling. Vulnerability, loss of control, anger, irritability, depression, mood swings, uncertainty about the future, and lack of empathy. So what I mean by that is a lot of people, and we see it with chronic disease, become very insulated, I guess. So it's everything becomes about them, and they have this inability to empathize with anything that's going on outside of them. And so you do actually see it, but these are some of the moods and emotions that are really common. So managing these emotions can be dependent on insight, length of diagnosis, level of disability and dependency. So let's just have a look at depression and anxiety strategies, because these are a couple of the most common ones. So depression might be related to grief and bereavement, and coping skills, a loss of familiar environment, loss of role, and a change in self-image. And I guess, this is for other people as well, but what can you do for these people? So provide them with a peaceful environment, avoid identified triggers, give them appropriate levels of light, lots of family support, medication, and counselling. So let's not forget counselling. So some of the things that you might see when a person is depressed, you might see that their moods changed. You might find that they're more isolated. You might find that they're not eating, or they're overeating. You might find their fatigue levels are increased. You might notice that they're complaining more of pain and headache, or staying in bed. Another really common thing is hygiene neglect, which is can be quite common side of depression. So what can you do? Report those changes in emotional state to the GP and the family. Discuss how different it is for them. Be alert for, and I must add here, so be alert for severe depression and any sort of signs of suicidal ideation. This is when we're referring right at the beginning of the slides about red flags. This is a red flag. So if you notice that this is escalated and you have some concerns, you must speak up and get some help for that person. So signs of a high level of anxiety, restlessness, irritability, poor concentration, headaches, again, and unexplained pain, sleeping difficulties, panic attacks, racing heart, sweating, dizziness, nausea, changes in behaviour. Now, this can be related to a change of environment, grief, pain, isolation, potential strategies. So again, very, very similar to depression. Deal with the cause, increase your involvement of family and friends, maybe medication. But again, report the changes to the GP and the family, identify the triggers, and get onto it as soon as possible. Cognitive issues are another one of these invisible signs, and can vary quite significantly from person to person. Now, self-reported cognitive changes are probably one of the main reasons people leave work out there in the community. Sometimes someone with MS with quite advanced cognitive decline may not actually have the insight or the flexibility to actually recognise what's going on. So you can see on the list there's some common cognitive issues. These are some of the more common ones, and functionally, this is what we see. So information processing. So what we mean by that is dealing with information gathered by the five senses. So they have trouble following conversations. Their memory, acquiring, retraining and retrieving new information can be very, very difficult. Attention and concentration. So they might have difficulty following instructions and poor memory recall. They might have a divided attention, so they may not be able to watch a TV show or news with family or friends, or and then have a conversation about it. So can't sort of focus on the two things at once. New learning. So they might need longer. They might need more written step-by-step information and more support to learn new systems. Their executive functions might be affected. So they tend to dive into tasks, becoming really disorganized, especially if multitasking or with completing tasks. Sadly, that tends to lead to great loss of self-esteem and decreases mood and depression. Visuospatial functions. So what I mean by that is your eyes might be perfectly able, but your brain's not able to make sense of the information that your eyes are taking in. For example, walking into a wall rather through the doorway, or you're trying to concentrate on guiding your hand accurately to the item that you want, but you can't get there. The other thing is verbal fluency, so word finding. So not being able to contribute clearly because they're unable to find the words. So you can imagine how frustrating this can be to somebody, and you need to be a little bit patient if you've got a resident that is struggling a little bit with cognition, and recognise that this is a problem and come up with some strategies to work with them. So just some thinking and memory strategy ideas. So look for the resident's strength and abilities to improve his or her quality of life. So, involve them, I guess. Using management strategies like visual aids, whiteboards, journals, diaries, photos, visitors' book, clocks. It might be that you stick Post-it notes up if you need them to remember something. Very, very, very good simple strategies. Respond appropriately to behaviours of concern and conflict. Facilitate communication and development of a productive relationship with the resident. And one of the things that's really important is to maintain routine. Be consistent, reliable teamwork as directed in the care plan. So consistency and routine is really important for these people. You can refer to speech therapy, occupational therapy, and neuropsych. Physical exercise has been shown to increase brain volume and connectivity. So encouraging them to be involved in activities can be a really, really good strategy. Cognitive rehabilitation exercises. So using brain training games or apps, you can get a rehab specialist in. Visual and verbal associations might be helpful. So, for example, your resident's trying to explain who just came in to visit. So, for example, Mr. King is the man with the crown on, or putting meaningful tags onto words or names such as Carol, the lady who works in the library, as we talked about, using, if they've got a smartphone, using that, prioritizing tasks to focus on one thing at a time, removing distractions. For example, you know, turning down when you're going into the room and you're trying to talk to that resident about something really important, that you want them to concentrate on, turn their TV down or off for that moment so that they're concentrating on just the one thing. Breaking down longer tasks into smaller chunks. Avoid doing things when the resident's tired or anxious so that they have more chance of staying focused. And that's also dealing with any sleep problems they have. If the cognitive problems are worsened by other MS symptoms, getting those symptoms treated can help. Using cooling therapies such as fans, air conditioning, and managing symptoms such as stress, anxiety, all of those sort of things. You know, try guided relaxation, aromatherapy, breathing exercises, mindfulness, meditation, yoga, all of those things that, you know, are probably a really good thing for all of us to use as well. Bladder and bowel dysfunction is very common in MS. Involuntary muscle spasms of the bladder and sphincter muscles can lead to urinary incontinence, urgency, failure to empty the bladder, inability to pass urine, also irritability of the bladder causing frequency. Common bowel problems are loss or much reduced peristalsis, the wave-like motion which moves our waste along the colon, loss of the gastrocolic reflex, and spasticity of the anal sphincter. So you might find that your residents will pass wind or sometimes feces without control. And sometimes if they don't have any feeling, they may not even realise that they've lost control. And they may have a bit of spasticity of the colon. And as you can imagine, you know, losing your bladder and bowel control is a stressful thing for anyone. And so how you respond to that and deal with that's really, really important for this person's self-esteem. What can you do? Refer to a continence nurse management and get some nurse management so they can actually see what's going on with the bowel or the bladder and make that recommendation, whether it's something simply that you can manage there at the facility, or do they actually need to see a urologist or a gastroenterologist? Establish a bowel regime in conjunction with diet, oral preparations and suppositories. Maintain a healthy, varied diet to avoid constipation, which will also impact on bladder function. Decrease caffeine, tea, so your tea, coffee, cola drinks. Make sure that they're having plenty of water. Establish a regime of 2 to 2.5 hourly to prevent incontinence. So you might need to record frequency of voiding to establish this pattern. So you might need to keep a bowel and bladder diary. Skin integrity is really important when someone has bladder and bowel dysfunction. Positioning is really, really important. So you can see in the pictures there, a healthy position and an unhealthy position. It stands to reason, logic and gravitation and that, positioning will actually help. There are lots of medications for bladders that GPs can have a look into. It may be that your patient needs some manual evacuation. It could be that it's appropriate for catheters and continence aids. And I guess one of the most important things here to say, it's really important to do regular urine tests because sudden changes in symptoms might be due to that urinary tract infection, which we spoke about a little earlier. Heat sensitivity. Heat sensitivity or temperature intolerance, it's really, really common in MS. In fact, some people might actually talk about cold sensitivity as well. But if we're talking about heat sensitivity, Many people find that when they're exposed to hot weather or an increase in temperature, they become more fatigued. And in some people, increases in internal body temperature, even as little as half a degree, can cause nerve conduction to slow down and lead to what appears as a worsening of symptoms. This is one of those triggers that we spoke about before as a pseudoexacerbation. And once the trigger's removed, the core body temperature comes back down, the symptoms settle. So, some of the most common reasons for this temperature increase: hot weather, having a hot shower, physical exertion, infection leading to fever, stages of the menstrual cycle, or even a hot drink. So what can you do? Fans, mattress cooling, air conditioning, ice. Ice is a really good way, or icy poles, to cool inside out. Cotton clothing. Consider getting cooling vests and neckties. Paracetamol if there's a fever. Tepid showers, and limiting activity to the cooler part of the day. Pain is really common in MS, and pain is often described as dull, aching, burning, sharp, electric shocks, spasm. And we also class into these sensory changes: numbness, tingling, prickling, altered temperature, altered colour. Sometimes you'll hear them saying, "Oh, I feel like I've got ants crawling on me," or water dripping down my legs. It's coming from the nervous system. And there are three main types of pain that people can complain about: neuropathic, musculoskeletal, and paroxysmal. So neuropathic pain is probably the most common and the hardest to manage, and that's coming from the nervous system. When we're talking about musculoskeletal pain, we're talking about the pains that people are getting from their joints and their muscles, and that can come simply from being immobile and having a lot of spasticity and contractures. Paroxysmal pains are those sharp, stabbing, burning pains that come and go. Pain is very common and can exacerbate with fatigue, insomnia, and immobility. And it can also increase as person is progressive. So what can you do? Firstly, I'd suggest a physio and OT assessment, looking at equipment, positioning, movement. We're looking at medications for pain and spasticity, so in particular, neuropathic medications. Address poor sleep again, massage if tolerated, maintain skin integrity and hygiene. Refer to a pain specialist if required, so if you can't get to the bottom of it. And a big part of this is mental health support. We know that our mental health and physical health directly impact each other. So sometimes addressing that mental health as a holistic part of treating pain can go a long way in helping these people. Having MS doesn't preclude a person from other health issues. So we've got to remember that we all age, and aging in MS, we've also got to consider things like dementia, menopause, prostate, arthritis, and frailty. So what else could be going on for your resident? Is it an age-related condition? Address the other comorbidities. Do they have diabetes, heart conditions, urinary tract infections, problems with their nutrition? Are they able to exercise? Do they have some mental health problems? Are there medication side effects? Establish if it's MS. Is it something else? Something comes up a little bit different. GP review. Let's exclude everything else and then work our way back. Really, really important. So take some consideration, having a look at your person as a whole. Have a look at their age. What else could potentially be going on at this point? When you know your resident's story, it assists you to understand. Really important to have a flexible approach. Know the person, establish a relationship. Try to understand problem behaviour. Be aware of triggers, yours too. Try different strategies. Look for strengths and abilities. Give changes enough time to work. Ensure a consistent approach to care. And don't take behaviours personally. Work within the client's best time. Take into account fatigue, medications, and time frames around both of these things. Consider why certain behaviours are possibly regarded as a difficult person. Have a look at the whole picture. Sit down and have that discussion. And if you go in and you don't get anywhere, see if someone else can take a different approach. And if you and that person, and you've tried all sorts of approaches, reach out, call someone, talk to the GP, talk to the family, talk to their healthcare professionals, call us if you need to sort of troubleshoot and see if you can come up with some strategies too, so that it becomes a better environment for your client and for your staff. So in summary, a person's symptoms will vary over time. Individualised support should be offered to enable people to live well with the disease. And please reach out for information and advice and support to manage your client, particularly if the behaviour or the symptom is really, really difficult to manage. I hope that has covered some of the main sort of things that we see with people who are requiring a lot of care for MS and for your residents. If anything there has brought up any questions, anything that you feel that you would like to discuss one-on-one, please call MS Plus on 1800 042 138 and ask to be scheduled in for a call with one of the nurse advisors so that we can sort of have a bit of a chat and maybe see where some of the issues are and maybe give you some advice around how to manage it. MS Plus, we're here to help you thrive. So no one has to face MS alone, and we are here to support you with your resident. I won't go through all of our services, but there are a lot of services that we do provide. So please have a look at this page. And if there's anything on there that you think would be of benefit to your client, please call MS Plus and have a chat. As MS advisors, we are here to provide that service for clinical support. So that's your 1800 number that I just mentioned and that are on these slides. There are lots of resources on our website for you to have a look at. There's lots of webinars, podcasts, articles, newsletters. Please go through the website and have a look. And if you're interested in any of those, have a look at them. And if you're not sure how to access them, give MS Plus a call and ask too. There is a great webinar library there that particularly hones in, I guess, on particular symptoms as well. There's also a lot of medication fact sheets if your client is on any of the medications and you want to learn a little bit more about those. This is your Plus Connect number and the email address. Please utilise us in any way. We're here to support you. And once again, thank you very, very much for watching this. A lot of heartfelt thanks that you are reaching out to get some support for your resident living with multiple sclerosis. So thank you very much.